Thank you, Dr. Nancy, for the time that you have for us today. I'm so glad that I can ask you some question. Thank you that you want to have more information for parents and patients, pandas from Poland and from whole Europe.
Absolutely. And thank you for inviting me.
Okay. You need to know that I have been on lectures by Dr. Nancy in Boston ILAS conference, and they were on pandas, and I really realized that she knows something. And later on, I read book by her. You can see on this armchair, the cover of the book, Demystifying Pandas is very helpful, and I recommend the book. So I'm so glad that we could talk. I have some questions, and I know that I'm only touching the problem. So the first question is, what makes pandas so complex? Because for the many doctors, if we're talking about autoimmune disease, like for rheumatologists, immunologists, in their perception, this disease should be something very simple or linear. But when we think about pandas, it's becoming very complex. So what makes this disease complex?
Well, I think it's not an infectious disease, which many people think of when they think about strep-induced problems, for example. It is an immunologic disease. And what is happening is molecular mimicry. Like we know from rheumatic fever in Sydenham's chorea, the antibody response, rather than attacking the strep in the throat or the rectum or wherever else it is, or any other germ, the immune system is instead crossing the blood-brain barrier and attacking the basal ganglia. I think that's the first thing, not realizing that it's an immunologic autoimmune disease rather than an infectious disease. The second thing is the neuropsychiatric symptoms can be very diverse. Meaning it doesn't have to be just OCD. It can be restrictive eating. It can be anxiety, tics, sensory abnormalities, rage, aggression, anything that the basal ganglia and that area of the brain is responsible for, you can see those symptoms. And then the third is the juxtaposition of the trigger to the neuropsychiatric deficits or problems that arise. It can occur as quickly as within the next week, or it can occur up to 3 months later, depending on the trigger that starts it and the child's own immune response. Do they have some amount of immunodeficiency, as 30% of the children do? Was it induced by COVID, for example, or a Lyme disease like Bartonella, Borrelia, or Babesia? Was it induced by mold? Those may all be much slower as opposed to strep or mycoplasma viruses of other sorts, which may be more quickly. So there are many factors that make it so complex.
Okay, so sometimes I understand the problem for the doctors is to comprehend it, because rheumatologists, they see one part, immunologists the other part. That's why I believe there's some problems sometimes to make the diagnosis and good treatment.
Absolutely. No, I agree with you.
Yeah, I have the question about predisposition, because you mentioned triggers, and let's talk about predisposition. Like they could be some genetic predisposition, but also something that you can catch on the way, something from the environment. And some children, they can develop pandas and some will not develop. So what do we know about predispositions?
Absolutely. So this disease affects about 1 in 200 children. About 25% of children who get COVID, even a mild disease, can have subsequent neuropsychiatric symptoms. In our practice, which is in the epicenter of the Northeast, where Lyme disease is very common, up to 42% of our patients will have test-proven evidence of Bartonella. But the major diagnosis is 1 in 200 children. So we always use the phrase, genetics loads the gun, environment pulls the trigger. The genetics that we know about are that these children will have HLA-B alleles similar to other children with other forms of autoimmune disease, vasculitides, etc., like HLA-B32, HLA-B52, and B58. So those are known. We also know that they have abnormalities in the Th17 cells, which increases as per Dritan and other doctors who have shown the influx of the antibodies through the blood-brain barrier. Many of these children with Th17 and other Th1 versus 2 cell differences will have more of a genetic predisposition. And then the third thing is 64% of children will have a family history of autoimmune disease. So you need to look for that, because if they're in first degree relatives or in the child themselves, other autoimmune disease, inflammatory bowel disease, autoimmune thyroiditis, diabetes, or other autoimmune diseases, then those children are much more likely to suffer with this disease.
Okay, so in your practice, do you make some genetic tests for children like this HLA alleles or some other genetic tests? They could be beneficial.
We do look for it, especially in atypical cases where we're not sure what the diagnosis is. We do that test. We also, in atypical cases, will do the Cunningham panel, which is the test of the calcium modulated CAM kinase protein that is elevated in Sydenham's chorea and also elevated when a child is in a flare from strep-induced PANDAS. In addition, we're working with a company called Intellex DNA. The medical director is Sharon Hausman Cohen, who is doing research now on the SNPs, the single nucleotide polymorphisms, that are more likely to be positive in children with PANS or PANDAS. There's no definitive research there yet, but things like tumor necrosis factor alpha and abnormalities in interleukins like lower levels of IL-10, et cetera, have been seen in these children. So we're actively looking at those to see where we can find these SNPs that may be more likely to be part of the profile for children with PANS and PANDAS.
You mentioned that you make the test for atypical cases. So I understand that in that cases you want to know HLA alleles, but also polymorphisms like these SNPs. And it's not like whole exome sequencing, for example. When you will make, for example, whole exome sequences, only in very, very atypical case?
Yes. Okay. As a clinician who, most of this testing is out of pocket here in the United States. Yeah. I grew up in West Virginia, which is a very poor state in the United States, and I still walk around with my mouth open at the cost of everything, including me for that matter. But I try very hard, if a child has a very typical case and is getting better with easy and safe interventions, then I may not go to that other testing. I will participate in the research with other people that are doing the research, but for me, it's about the N in front of me, the child in front of me.
Yeah, in Poland it's pretty the same, like it's measured like the treatment diagnostic that they are out of pocket of patients. So also me as a doctor, I want to be ethical and give advice what is really necessary or helpful or what should be done as first line, second line, and so on. Maybe another question about this predisposition, and maybe it's not the same topic, but I realized that you are co-author of this publication about folic acid deficit in the brain, and it was shock for me because I was thinking that this is a problem only of autism children. And then I realized that with PANDAS statistics, they are not so, they are almost the same. So maybe, I'm not sure if it's a wise question. Is autism somehow also predisposition that somebody with diagnosis of autism, because of these, different problems can develop easily PANDAS, or it's not the case?
Well, I think there are a couple of answers to that question. So number one, I think and this is all supposition right now, I think the abnormalities in folate receptor alpha autoantibodies in children with PANS and PANDAS are cross-reactive to the antibody molecular mimicry from whatever the underlying trigger is. In those children, what we've seen clinically is as we get their PANS, PANDAS better, their folate receptor alpha antibodies also decrease, and they don't have a lifelong need for folinic acid to treat that. As opposed to those children who have it with autism, it may be much more genetically predisposed and a lifelong need. We don't know that for sure. Secondly, autism and PANS PANDAS are at the very least overlapping Venn diagrams. There are groups of children that have both autism and PANS PANDAS. There are also some children with autism that were probably misdiagnosed as autistic that actually have PANS PANDAS, and once you treat it appropriately, they no longer have symptoms of autism. But we came to this study because we were originally part of Dr. Quadros's study of using the folate receptor antibody test in diagnosing cerebral folate deficiency in children with autism. Then we had children with autism and PANS PANDAS, and we're seeing it positive in them also. And then we started to do it in children just with PANS PANDAS and finding that it was also positive. So that's how we came to the study and came to find the 64% in our practice compared to 71%. So as you said, very close in the autism population.
Okay, thank you. It's a lot of information.
Yeah, I know.
Another question, you mentioned already Bartonellosis as something additional that test should be done. But generally, I have a question. What about Lyme disease? Can it also play a role, like maybe predisposition? Because we know that borreliosis can make a mess in the immune system. So do you see Lyme disease like quite very often? Could you give any comment on that?
Very often, yes. 41% of the ticks in the Northeast now carry all three, Borrelia, Bartonella, and Babesia. And the only difference is with Borrelia, we see more classic joint, muscle, the pains, headaches, brain fog, etc., and not as much neuropsychiatric symptoms like the rage, tics, anxiety we see with Bartonella, and the dysautonomia, anxiety we see with Babesia. So absolutely Borrelia can cause it. But the significance of the neuropsychiatric symptoms usually has Bartonella and Babesia together with the Borrelia or alone.
Okay, so as I understand, if you have like only Borrelia, not so many psychiatric neurological symptoms, but if we have this BBB together, that it can cause more problems. I wonder what could be the difference between, Europe and United States, because generally Lyme disease in United States, it's more like rheumatological joint problem, and in Europe, it's more like neurological. So maybe it's a little different here in Europe.
I'm not sure, because I think you're more adept and open to seeing it as a problem neuropsychiatrically than we are in this country. So for the most part, people with Borrelia get treated, but most physicians are not putting together the neurologic or neuropsychiatric symptoms with the Borrelia. So only if they're only treating Borrelia and not getting better are we then seeing them and finding the Bartonella and the Babesia. So I think we're treating the Borrelia more in this country without understanding the Bartonella and Babesia and treating it effectively, but treating the Borrelia for other symptoms than just neurologic or neuropsychiatric symptoms. I think in Europe in general, not to stereotype it too much, but based on the research that comes out of Europe, the physicians that I've talked to there's a much greater understanding and acceptance of the neuropsychiatric symptoms of Borrelia than there are in this country.
And you mentioned, you started with this, phrase that PANDAS, it's not infectious disease. It's more like a immunological. You give some information about mechanism. So now I wonder if we have some chronic infection, like not only, tick-borne infection, but even you mentioned mycoplasma, for example. So how important is to eradicate, to treat, to eliminate these chronic infections if I want to fix, the immune system?
You have to do that. Absolutely. It's just you can't do that alone. So for me, it's always a three-pronged approach. You treat the underlying trigger. And if it's infectious, then you have to treat that until the tests are better. It doesn't mean you continue to use antibiotics once the tests are normal because the child isn't better. The second prong of the approach is the immunologic, providing immune modulatory support, anti-inflammatories, etc. That often needs to be more long-term, but also in the short term with treating the infectious agent. And then the third, of course, is always treating the symptoms, which may be sleep disturbance. We want to treat that because that's the most affecting the family and the child. It may be the tics or the anxiety or whatever it may be. But we need to do the three-pronged approach. It's just what people who don't totally understand the disease end up doing is having them on chronic long-term antibiotics without seeing if they're really improving with that, without trying to wean it or without trying to move it toward more herbal approach that is safer, as effective, and better for the gut than long-term antibiotics.
Okay, thank you. Another question is actually probably a huge topic, and I wonder how you want to answer my question, because I have a question about strategy, how to treat, PANDAS, because we said that there could be so many problems, different infections, immunological problem, some other dysregulation in immune system, gut problem, and usually, when the doctor can see the patient with so many problems, let's see all the tests they are on the desk. And so how to start everything? Probably you have some, like your strategy, how Dr. Nancy is doing that. So could you please share a little about that?
So first, I have about a 30-page questionnaire that they have to fill out before they see me, and I review that before they come in. And usually I'm finding the trigger, if not a few triggers, from that history. If I don't, then that's what I'm asking for. What was going on before this child changed? Did they have strep throat? Did dad have COVID? They were fine, but there was COVID in the house. Did they get bit by a tick? Was there mold in the basement? I'm looking for what the trigger is. Then based on that trigger, then I will start the intervention for that trigger. The second is, what's the biggest symptom that is affecting this child or family? If this child isn't pooping at all, stooling, that's the first thing I'm going to treat, because you can't put a lot of other interventions in if a child is all bound up. As I said earlier, if the child's not sleeping, nobody in the family is sleeping. So that's the first symptom I'm going to treat, because the immune system and the detoxification system won't work unless the child is sleeping. And then I'm adding an immune modulatory intervention. So let's say that the trigger was both COVID and mold. I may add a monolaurin that has a biofilm buster because it's antiviral and very good for COVID, but also has some antifungal properties. So that may be the first thing I add. I may add turmeric because that's been a wonderful anti-inflammatory for me. And then I may add magnesium or valerian or something to help them sleep. So I'm not adding 20 things at once. I'm looking for what's the most likely trigger, what's the most significant symptom that they're dealing with, and then what immune modulatory support do I want to start with. And then at that first visit, I'm also getting the frat to see if that's an issue and adding that if it is. I'm getting, depending on the history, I may be getting testing for tick-borne diseases. And I do that more often than not, because remember, many of the ticks are the size of a poppy seed. and they're still transmitting the disease. So if they're coming from my area of the country, I'm almost always looking for that. And then if I hear a water damaged building, I will also be looking for mold. So then I will layer in things. And I also often will give them a couple of things. Okay, if the turmeric doesn't work, here's another anti-inflammatory, and do it in that way, so that I've got at least one thing for each of the three prongs of the three-pronged approach, and then basing the rest of the treatment on their initial response to those.
So we have like three groups, like triggers, main symptoms to help the quality of life, not only of child, but the whole family, and immunomodulation. But as I understand, some of them you will use like together, because, like to eliminate mold toxin, it can take a year or two, a few years.
Absolutely.
Sometimes with the diseases, you start with antibiotics, then you go for herbs. It can also take a long period of time. Okay.
Absolutely. So that's an excellent point. This is a marathon, not a sprint. Yes, if you get a child right away and start them on the correct antibiotic for strep-induced PANDAS, they may get better very quickly. But even that child should be on preventive, either azithromycin or herbals, to prevent the second flare in that next winter season, because that second or third flare can be even more significant. But when parents come in, I always remind them, all right, we're treating the symptoms, we're treating the most likely trigger, but there may be many. And this is a long process. We're not expecting the child to get better right away. So it is very much setting the expectations that we have a lot of work to do, and it is a marathon.
Okay. And could you give more comment on immunomodulation? What would you use for immunomodulation?
Right. So turmeric is by far my favorite. There's a wonderful turmeric that I have that in my line, there's also one available by Nutramedics. That's a very good anti-anxiety and anti-inflammatory. I also really like phospholipids and resolvins. So there's a product known as specialized pro-resolving mediators that has been very effective in COVID, but also can provide that immune modulatory support. The same way essential fatty acids or fish oils can. I also use ibuprofen or other NSAIDs, and ibuprofen at 10 milligrams per kilogram can be a diagnostic test as well as therapeutic test. If a child is having tremendous tics or brain fog or OCD, and it gets better with either in severity, intensity, or frequency with ibuprofen, that tells you it's an inflammatory response. So turmeric, specialized pro-resolving mediators, fish oil. If the child is constipated, I also like aloe as an intervention because it has good laxative properties as well as anti-inflammatory properties. If they have anxiety, I may choose hemp oil or CBD, not with THC, but just CBD alone, and that works very well. And then I will move on to other things like LDN, low-dose naltrexone, which in this country needs to be compounded, so more of an expense to the family. So that's why it's not usually first line for me. Very rarely, I can probably count on both hands in 30 years the number of time I've used it, but very rarely I will use steroids. And then I use a lot of Hellman therapy. Hellman therapy are ways to induce immune tolerance, giving a mutualist that the body is used to seeing to induce this immune tolerance. And in using that, I avoid IVIG, again, very expensive, very hard to get covered by insurance in this country. And only 20% of the children in my practice need to go on to IVIG, plasmapheresis, monoclonal antibodies, any of those, because I get them to respond usually to these other agents I just mentioned.
It's very interesting you mentioned Hellman therapy because it's not so popular in Europe. We know about that, but I do not have any experience with that. In United States, you have like FDA approved, products. How does it work?
Dr. William Parker is a PhD, or was a PhD at Duke, that first found this type of very safe helminth therapy called HDCs, which stands for Hymenopus diminuta cysticercoids. It's a grain beetle worm egg that he found in his studies induced immune tolerance, but also decreased in rats OCD, anxiety, helped them learn the mazes faster, and the rats were healthier. So he has now retired from Duke and is actively trying to get it FDA approved. It has been used for some years as an adjunct therapy in inflammatory bowel disease in this country.
Yeah.
But in general, it's an off-label product. Dr. Parker has it. There is a company in England called Biome Restoration that harvests these grain beetle worm eggs. I don't usually get it from that company here in the United States because it gets stuck in our customs. But in Europe, in England, in Africa even, I've had patients that I've mentored there that have used it from Biome Restoration very readily. That is, it's biomerestoration.com. There's a lot of information there, as well as a blog on my website about this intervention, because I do find it very safe. A couple of things about it: I do not use it if a child is constipated, because what you're giving is an egg. And the egg transverses the GI tract, induces immune tolerance, but does not set up shop. It does not hatch. If you're constipated, though, it could hatch, and then you'll get an infestation. Not an infection, but an infestation. Very, very easily treated with biltricide, but still something I want to avoid. Don't use it when they're constipated. I don't use it when they're on other immunosuppressive medications. They're on sulfasalazine for inflammatory bowel disease. They're already on IVIG. I will not use it. And then third, if a child already has a lot of abdominal symptoms, cramping, and especially if they're nonverbal, if they're one of our non-speaking children with autism, I will not use it, because that's the one child I had a significant infestation with. So it's made me back off in those cases, but it can be a very effective intervention for many children.
Okay. It's very interesting what you say, that it's not for inverbal. Recently, I have a conversation with Dr. Arthur Kriegsman. It was more on autism, but he told me that many of the symptoms, like aggression, autoaggression, different stories, they are symptoms of the child with some gastrointestinal problem that they cannot communicate, so they are trying to express it in the other way. So, you know, if the child is non-vertebral, I understand that it can cause more problems then.
Yeah, totally agree. And, you know, the gut isn't the second brain, it's the first brain. And all of our neurologic problems start in the gut. So I will heal the gut first, help these children with autism, for example, for their guts to get better in other ways. Once I do that and they don't have ongoing gut symptoms, then I may try the helminth therapy later, even if they are non-speaking. The other thing with the non-speaking children is there's a wonderful research through Spell to Communicate that is showing that many of these non-speaking children are actually quite brilliant. And it's a motor problem rather than a speech problem. And finding that out and helping them learn to communicate non-verbally through first pointing out letters and then eventually typing, it has shown me that many of the children that I thought were just anxious from gut disease or had all these other issues were really just locked in. And now they're at wonderful colleges. They cannot speak, but they can type, and you know, they've graduated valedictorian from their classes once we get the other underlying problems fixed.
Yeah, I agree. You know, recently I have like a few story of kind of miracle. the child was with mutism, not talking at all. And after short period of time of some treatment, the child started to talk, but not just few words, but whole sentences.
Yes.
Like the child known before, knew like all the speech, but was not able to break through something.
Absolutely.
It was amazing. Mhm.
Yes, yes, I see that quite regularly. And we see speech disfluency with PANDAS also. It can affect the speech center, and in treating the PANDAS, if it occurred more abruptly, that can get better. The other child I recently had was a cerebral folate deficiency, and leucovorin or folinic acid brought that speech out because that was treated. So absolutely.
Yeah, I agree with, this problem with folinic acid, that it's causing a problem for speech. And I have some story that supplementation of folinic acid helped a lot, and some children, they started to talk. Now in our
Yes.
clinic, we will start also a folinic acid IV additionally to oral. So I also hope that it can help even more.
That's great. Yeah, absolutely.
I have another question. Maybe it was not in our list, but you mentioned before that Lyme disease is very common, but also I want to ask you, and what about mold toxin? Because more often I'm making some tests for Aspergillus. Like in Europe, it's probably not so much environmental. Of course, it's also environmental from the houses, basements, but sometimes it's just on mucous membrane somewhere in the body. And I realized that so many children, they have some contact with Aspergillus, and I'm making a test for mycotoxin, and they are full of mycotoxin. So how often you could see how big problem it is?
Very big problem, and I think very underappreciated, and I think also very misunderstood. What a lot of people do when they see mold mycotoxins is they just want to bind them out. But actually, they can get worse with that. The biggest problem with mold disease is activation of the mast cells. So you get overactivation of the mast cells or mast cell mediated disease. So antioxidants like vitamin A, vitamin D, zinc, essential fatty acids or fish oils, all before binders. And most important, especially with aspergillus or high ochratoxins, is bioflavonoids or antihistamines, because that denatures or breaks down the ochratoxin. So that's an anti-inflammatory category I didn't mention, but that I use very commonly, especially in our mold kids. So quercetin, luteolin, rutin, cromolyn sodium, which is a mast cell stabilizer, other antihistamines, cetirizine, for example, hydroxyzine, prescription-wise, I have had very good success with. So with mold, if that is found, I highly recommend treating the mast cell activation, which is almost always there, and using only natural food-based binders like flax and chia, pumpkin seeds, sunflower seeds, psyllium, modified citrus pectin, rather than the charcoal, which can actually constipate them more and make the whole process last even longer. So I use a lot of bioflavonoids also in those children. But mold is often, it's very common and very prevalent in the Northeast. So often it's part of the problem, even when the parents don't see it. Only thing in getting those tests, I do want to say it is best, even though it can be a minor problem, to remove any moldy foods. So that includes especially cereals, aged cheeses, fermented foods for 3 days before doing the test to make sure that it's an accurate representation of what's going on.
Okay, thank you. There are a lot of information, but the last question is actually some kind of conclusion. What could be your advice for parents of, children with PANDAS, because they could feel lost with so many information, so many problems, but probably, you talk to them on a regular basis for years, and maybe you have some important advices that they are like a good for majority of them.
Right. So one, don't give up. There is always hope. I got into this because of my own son 17 years ago, and now he's getting his PhD in chemistry. So there is hope. The second is don't feed the beast of the disease. A child that is going through this still needs to try to do their chores, try to do their homework. A lot of times we think, oh, my child is sick, I need to coddle them. No, we need to still have expectations. And I am a big believer in therapy, cognitive behavioral therapy, CBT, DBT, ERP, whatever works for that child and that family. And then the third is you can do this even if you don't necessarily have a doctor that totally believes in it, because many of the options are very safe for children, herbally, botanically, nutraceutically. And I have a membership that is open to parents that, are welcome to join to learn more. I have 50 some, maybe up to 70 now, 2 to 5 minute videos for people to watch, lectures, as well as monthly teachings and resources, lots and lots of things. So there is a community, there are people that want to help, and it's just about not giving up hope.
Mm. You also mentioned a lot of very safe and natural treatments, and I like it so much because the parents will feel that it's not dangerous. We really need to probably put emphasis on that. I have presentation from your lectures, and I guess we need to make some information for parents about what supplements are safe, and they could start with that even if they don't see the doctor. And also, we really need to give a link for your book, because I really believe that for many parents it could be really helpful.
Sure. And I just wanted to let you know, I just taped my audiobook and listened to it over this past weekend. So it's going to be available soon. And the audiobook has 5 new chapters, one on Bartonella, one on Babesia, one on COVID, one on mold, and one on the cerebral folate deficiency, folate receptor alpha antibodies that I didn't think I touched on enough a couple of years ago in the book. So those are all in the audiobook, and that will be available soon. Sorry, it's not in Polish
great.
or it's only in English so far.
It's still great because many people, they speak English, and
Yeah.
if we listen to the book, we can even tell the story, like spread the message. So it's amazing because when you mention all these problems, I think it's good to cover with more information. The book is excellent tool for that. So I will wait for that, and I hope that it will be helpful for many other people. Okay,
We will let you know.
Dr. Nancy, I'm so helpful for the time, for the questions. A lot of information in a short period of time. Maybe in the future we should continue our conversation and talk about the other problems, because there are a lot of things to discuss. But at the moment, I'm very grateful. Thank you so much.
Thank you very much. Glad to do it again.
Okay, thank you.